Over the years, assisted livings have evolved from just assisting with activities of daily living to a long-term care alternative for seniors who require more assistance but do not need 24-hour skilled nursing service. As a result of the evolution, caregivers are now charged with greater responsibility, which requires specialized training skills and monitoring to provide safe and effective care. With this increased responsibility comes increased liability, which necessitates the need for assisted living managers to be proactive in quality assurance and risk management to 1. Reduce the number of preventable injuries and accidents, thereby minimizing financial loss and potential litigations. To reduce the chance of a claim being filed by identifying and following up on incidents in a timely manner. To recognize trouble triggers and intervene in a timely manner. A key function of risk management is to identify adverse events that are abnormal and intervene promptly. The risk management team in assisted living should consist of the following at a minimum: the assisted living manager, the delegating nurse, and the care providers. When we talk about risk management in assisted living, we are talking about different events and/or incidents that affect resident care. Common areas of concern center around the following: medication errors, falls, pressure sores, dehydration, nutrition and weight loss, staffing issues, documentation issues, wandering, abuse, and neglect. Medication errors. Safe medication administration ensures that the 6 rights of medication administration is put in practice each time medication is being administered. This procedure will ensure that the right person is receiving the right medication in the right dose, at the right time, via the right route, followed by the right documentation. A medication error occurs when any of these 6 rights are violated during the process of med administration. The right person means if I am going to administer medication to Mr. Jones, I have to ensure if this is Mr. Jones. Different communities have different ways of identifying the residents. Some of them would have pictures of the residents in the med administration book. And if you're not sure, you need to ask somebody in there who knows. Because in assisted livings, they usually don't have name tags or wristbands like they do in the nursing home. But this person has to be identified some way before this medication is given to them. We have people with cognitive deficits in assisted livings, people with dementia or Alzheimer's. Never go to a resident and say, "Are you Mrs. Jones?" If this person has Alzheimer's or dementia, they are going to be Mrs. Jones. They're going to be whatever name you have called them. Rather, you want to ask them for their name. What is your name? Be extremely careful, because a lot of times med errors have happened because people or med techs have given the medication to the wrong person. The right dose. You want to make sure that this is the right dose. If I wanted to give 20 milligrams of lisinopril, is this lisinopril? Is this 20 milligrams? I need to make sure that is the right person, it is the right medication, in the right dose. I want to make sure that if it says give 1 tablet, I'm only giving 1 tablet. And sometimes we may have to do a little bit of dosage calculation. The medication may come in a certain strength, and we may need to give 2 of that medication, or maybe half of that strength. We need to clarify with the delegating nurse and comply with the doctor's orders. Is it the right route? That a medication goes in the mouth does not mean it gets swallowed with water at all times. The oral route has about 3 ways of administration. One where you take it and swallow with water, or when you take it and put it under the tongue, called sublingual, or when you have to have it in the cheek, called buccal. So we have to make sure that this medication is being administered via the correct route that the doctor has ordered. Research has it that medication errors cost this nation about 1 million injuries, about 120,000 deaths, resulting in a staggering $37.6 billion each year, out of which about $17 billion were associated with preventable errors. Common causes of medication errors: not checking the doctor's orders. We have to make sure that there is an order, a current order from the doctor for any medication that is being administered. Not having a 3-way check to ensure that the doctor's order matches the pharmacy bottle and the MAR. Multitasking during the process of medication administration. Talking to the girlfriend on the phone, reading the text messages, looking at the email, these are all distractors and can cause medication errors. Not checking the 6 rights of medication. No established system for reorder levels from the pharmacy. Poor and illegible writing. If you cannot read the doctor's orders, please do not guess. Send it back, fax it back, call the delegating nurse, call the pharmacy, clarify all orders before the medication is administered. Understaffing is also an issue. When people or when a facility is understaffed, it means that the medtech may not be paying full attention to the process of medication administration. She may be in the process of doing the med rounds and the call bell goes off. Now she's divided between the medtech process and going to answer a call bell. This is divided attention and could lead to med errors. Do not take verbal orders or telephone orders from the doctor. If your doctor wants to give you, or if the resident's doctor wants to give a verbal order, you may direct them to give that verbal order to the delegating nurse, or they may call it into pharmacy, or they may fax it to you. Under no circumstance should the CMT take a verbal or telephone order from the physician. As a precautionary measure, management should institute policies and procedures to address these common causes. Assisted livings are also seeing an increase in the use of high-risk medications like Coumadin and insulin with aggressive dose adjustments. These medications should be coordinated very closely with the delegating nurse. All medications coming into the facility must be subjected to the 3-way check before storing in the medication cabinet or cart. If, however, a medication error occurs, that error must be documented and the assisted living manager, delegating nurse, and residence physician notified. Upon notification, medical directives will be given and must be followed, and an incident report should be completed and filed. Tidbits for writing an incident report. The incident report is part of the resident's record. and subject to review by regulatory agencies or during litigations. Incident reports must be completed immediately, but no later than 24 hours after occurrence. When writing an incident report, be objective in describing exactly what you saw or heard. For instance, if a resident was found on the floor by a pool of water, do not say, "I think she slipped and fell down because of the water." State exactly what you saw, i.e., resident was found on the floor and there was a pool of water beside her. And then state exactly what you did. For example, I assisted her back to the chair, or I called 911. Include only vital information. Document exact time and location of the incident and the names of the people notified. Avoid writing opinions on how the incident happened. If the resident is able to talk and tell you what happened, write their report in quote, saying the resident stated, and say what they said. Don't play the blame game. Stay away from statements like, "This happened as a result of poor housekeeping." Avoid hearsay. Each staff witnessing the incident should write a separate report. And once the report is completed, the incident report should be filed properly. Safe medication administration is a responsibility of all certified medication technicians in the assisted living program. With teamwork, we can keep our residents safe from preventable